I introduce you to amazing people like you who are doing great things in the world that I think you should know about. Well, today is the fourth Friday of the month, which means it's time for everything you need to know about heart disease to prevent it, to manage it, with a plant-based cardiologist, Dr. Monica Aggarwal, and she's going to be answering your questions. Please welcome her back to the show. How are you?
Thank you. I'm good. I'm good. I thought maybe I'd start by telling you a few stories and things that have happened in clinic. I see patients regularly every day. So I'm a preventive cardiologist. So that means that I take care of people with really complex lipid disorders or cholesterol problems that have been told that there's only one approach to this or that, or they've been told that they need bypass surgery and they want another approach. So um, I saw a patient in the last couple months, which has been a nice, neat patient. So I have patients like this every week, which is really fun. But this is a patient who was told that they needed bypass surgery, and they were about 70, and they needed bypass surgery because they had multi-vessel heart disease. So they had multiple vessels that were blocked, and that they needed bypass. So when we started the conversation, he was saying the funny thing is though that I've never had any symptoms. How is that? So, we started out the process, and sometimes these diagnoses come in a tricky way, right? Because what we've done is we're getting really good at screening with calcium score testing and CT angiography, which is when we put dye in the blood vessels, and we find a lot of disease, but sometimes that disease is not causing us a whole lot of trouble. And that's sort of the key there, is that sometimes it's important to do the screening, because then we can aggressively treat with lifestyle and medications, but you don't always need to get a procedure done, because if you're having no symptoms, remember, stenting in particular doesn't make you live longer, it just makes you feel better. And so that's important. We want to make people feel better. And there's more data coming out that you may decrease overall recurrent hospitalizations with stenting. So it's not that stents are not relevant or important. And bypass surgery has a lot of data as well in patients with a weak heart or with diabetes, that they do benefit from bypass surgery. But this patient in particular was not diabetic, had a normal heart function, and had absolutely no symptoms. And his diagnosis was based on sort of an abnormal CT, which led to another, which led to another. So, I have been taking care of this patient, and, I could tell you that same story of somebody from 7 years ago with a similar story. And often these patients, what we do is we put them on an aggressive lifestyle-based approach, but we also put them on aggressive medical therapy, and we're often able to keep them out of the hospital. So that's always a feel-good moment. I get letters from people 10 years later saying, you kept me out of the hospital, and I haven't had bypass surgery, and I'm still doing great. And those are always great stories for me to tell. Not everybody's going to get out of getting bypass or stent procedures, because sometimes you will need them. But there are many people that are in this middle ground space where they can be treated with medications and lifestyle, which is really awesome.
That's great to have a success story.
Yeah, I am lucky enough to tell you that that I get a lot of success stories, because I think the thing is that what people aren't doing enough of, and doctors aren't doing enough of, is teaching this combined approach of good medical therapy, good lifestyle therapy, and sometimes surgical therapy. And sometimes you need all of them. But what most people are doing is they're just so focused on one of those, like, oh, we have to go for this, or you have to get a stent, or you have to do this, that we forget there's so many other things that make a person better.
That's very cool. Do people come to you because they know you practice lifestyle medicine, or do they get to you because you're a cardiologist and then they find out you're interested in things like nutrition?
Well, a little of both. Truthfully, most of my practice is referral based. And so I get a lot of patients that are driving up. So I'm in Orlando, Florida, and people come up from Naples and Miami, Boca. People come from South Carolina, and they drive down, which is quite lovely, in Georgia, because unfortunately there are not a lot of us that do sort of this combined integrative approach. And so I get a lot of referrals, and the neatest and always the biggest honor to me is when my own partners refer to me. So there are other cardiologists, and they refer to me to take care of sort of their lipids and their nutrition and lifestyle. So I'm board certified in lipids. So I take care of, there are actually very few people who are board certified in just cholesterol management. And I'm one of them, which is neat. And because of that, I get a lot of referrals from my own partners to manage cholesterol. And these are people, who don't just need a little bit of this or that, or need, again, a multifactorial approach. And this is why my partners are referring to me. And that's always the greatest honor, because that just shows that people are starting to see that there's a need for somebody who has that combined approach.
Do they ever come to you as a patient? Your partners?
Oh, yeah. So when I was at the University of Florida, I took care of many of the faculty. I took care of lots of doctors, fellows, which are doctors in training or cardiologists in training, nephrologists and endocrinologists, and many. And the reality is physicians also don't want to take medication. And so they all come to see me as well, which is nice. And, I'm never somebody who's going to tell you that you can get off all your medicines or that you should be on zero medications. I will often tell you that we will work towards a combined approach. And usually by adding in aggressive lifestyle changes, you will come down and reduce your medications, but you may not get off everything. And so I don't like to give people false hope, but I love to give people hope, because there is so much hope in this space. The other thing, though, that people need to remember is you can't have it both ways. You can't say, I don't want to take medication, but I don't want to make the lifestyle changes. And so people think this is too hard or that is too hard. And sometimes a drastic health condition requires a drastic approach.
Absolutely. Why do you think more doctors in general and cardiologists specifically don't use nutrition for themselves or their patients? Because that's one field where where you really have seen improvement.
Yeah, it's just a lack of knowledge. And remember, it's not just a lack of knowledge, well, that's the biggest issue. So, 90% of cardiologists have never been trained or less than an hour of nutrition education in their whole career. So if you have that little nutrition education, how are you going to think of nutrition and lifestyle change as an option in terms of your healing process? So I just talked to a physician and internist who was in DC, and just today, literally an hour ago, and she was looking for mentorship, and she asked me, she's like, I'm working at this hospital, I'm so frustrated. With this, I'm trying to work on this. How did you do all of the changes you made it in Florida? And I said, it's because I'm a graceful lion. I don't, you got to be a lion, but you got to take time. And they were talking, she said that she was talking to some of the cardiologists, and they're all saying, yeah, all fine and dandy, pat, let's move on. And they're not as embracing nutrition and lifestyle. And it's just because they don't think or see it having a significant impact. And also because when you see a blockage, people want to fix it. And so they want to fix the blockage when they see it, and it's hard to walk away from it. But I think we as a group of cardiologists need to be better about walking away, even when we see the blockage. And so that's something I do a lot of. I walk away from a lot of blockages, and that comes with confidence. It takes time and experience to know when you can and when you cannot.
Yeah. Trish, who's watching live on Instagram, says, do you ever recommend calcium heart scans?
Yeah, I do them all the time. I think they're incredible tests. I've had it done myself. I think it's a great test. Not everybody needs one. So it's not like every 40-year-old or 45-year-old who comes in the door needs to get the CT, but there is a group of people in this middle zone who have some risk factors or may have high cholesterol or a strong family history who certainly do benefit from getting that calcium score test. And I do quite a few of them because I'm a strong believer in prevention. And part of that, doing the CT scan, which does have radiation, which is a negative, but overall, it has a great benefit because it allows us to know how to risk stratify somebody, how aggressive to be. I have 70-year-old patients where the risk score tells us that they should be on statin medications. And then I might get a calcium score. And if it's 0, meaning no plaque, I won't push that because that's pretty impressive to be 70-year-old and not have any plaque in your heart.
That's amazing. So Linda would like to know, do you actually get patients off their statins or cholesterol and high blood pressure medications? Is this something that you do and have done?
Heck yeah, man. That's like bread and butter for me. So I guess I shouldn't say bread and butter, man. It's hummus and bread and hummus.
Hummus and carrots. That's great. I love that.
Hummus and carrots. Yeah. It's so the impact of what you eat and how you live your life is so underappreciated. It's not about just losing weight, but making deliberate choices and what you put into your body. Potassium-rich foods, for instance, are extremely beneficial for blood pressure reduction. So there was a time last year, that I started having high blood pressure, and I don't have high blood pressure. I don't have that as a risk factor problem, but I was having high blood pressure. So I started myself on medication, because I eat plant-based, and I put myself on some medication. Of course, I started getting lightheaded, because I don't actually have a blood pressure problem. When I started getting better, my blood pressure went down. So I came off my meds. So I don't take blood pressure medicine. But it was an important exercise for me to also remember that because I eat so well, which I do, I hadn't worked on my stress. I'm also very active. I exercise, but my stress levels were through the roof. And so by just working on stress reduction and minimizing anxiety, meditation, and calming, I was able to, my blood pressures came down naturally. So really remembering that there's more than one component to high blood pressure, to any condition, and that you have to appreciate how much of a role stress and sleep and lack of movement and all these things contribute, to how you feel. And so for me, I got highly stressed out for such a period of time that I made my blood pressure go up. And then just by making my lifestyle changes again and kind of being like, oh God, I need to make a correction here. What am I doing? Something you and I just talked about, AJ, is remembering to take that time for yourself. What people don't realize is that there's a balance between the two nervous systems, the sympathetic nervous system, which is your fight or flight, and your parasympathetic, which is your rest and recovery. And most of us are totally out of balance, and we're so overactivated and with fight or flight. And with that too much fight or flight all the time, ready, ready, ready to go, ready to go, your blood pressure goes up, your heart rate goes up. And so, yeah, you can treat it with medication, or you can figure out what's wrong, which is what I had to do. I had to recorrect, and it's always a process, right? I mean, I'm a nutrition trained preventive cardiologist, but here I am needing a medication. Like, wait, what happened there? So it's because at the end of the day, all of us need, we all kind of fail once in a while. And the goal is not to condemn yourself for doing something wrong, but just kind of get better and get better. Now I'm off the blood pressure medicine, but it was a worthwhile experience for me to remember that so many things contribute to why we feel bad, right? And so for me, it was the stress and calming that down and taking time for recovery made all the difference.
So do the medicines, what do they actually do? Because I've heard some doctors say, well, you're just treating the numbers. So just to have a great number, if it's not, does it really do something?
Oh, sure. It definitely does something. So, I mean, we know that having good blood pressure, is important for good brain blood vessels. And so it can impact the heart, it can impact the kidney when your blood pressures are too high. And so what you might be saying is like, well, how do you know that this number is correct? Well, overall, we have seen with study after study, when people have chronically high numbers that are higher than the threshold numbers that we use, they're at higher risk for certain illnesses, like I mentioned. But if you have one high blood pressure or a couple of high numbers once in a while, well, that's actually normal. In fact, when you exercise, your blood pressure goes up, not down. It goes down when you stop exercising, but it goes up when you exercise. So it's actually a normal physiological response depending on what you're doing. But the key is to make sure that you are overall staying in that sort of quote unquote normal range. And that normal range is bigger than you think.
Interesting. Education Envoy on Instagram is asking, I'm a type 2 diabetic. What measures can I take to improve my long-term cardiac outlook?
Yeah, so it's a good question because most diabetics will die of heart disease or have a heart-related event. And that's why it's super important for all diabetics to be managed aggressively. Now, a lot of type 2 diabetics develop, the reason they have it is because they have insulin resistance, which comes from being overweight. And so it's very important to then retrain your body and your adipocytes, which are the fat cells. We need to kind of shrink them down and decrease them. And so lifestyle change and a dietary change in particular is super important to bringing down sugar, decreasing your insulin resistance so you can decrease your diabetes. Now, in terms of your heart disease risk, we are more aggressive with our diabetics in terms of having their cholesterol lower, making sure that their blood pressures are good. And so all those other risk factors are very important in our diabetics. So I always tell people, you have diabetes. Okay, well, you just have to kind of remember, look, work on the diabetes, but you have to remember that you you can't look at everyone else and say, oh, well, they just had a little chicken nuggets or they just had a Coca-Cola. Why can't I? That's not the way to look at this, to say, okay, look, everybody's got something. You don't get to pick. I had a dear friend die of ovarian cancer last year. She didn't pick that. You get what you get, and then but you do get to choose how you respond to it. And so making those changes. And so you have to be, as a diabetic, extra good about your lifestyle changes to heal your body and decrease your heart disease risk.
Yeah, that makes sense. And then we have another question on Instagram about juicing. Person is saying, I've been vegan for many years. My cardiologist tells me to stop juicing beets because they're high in sugar. I only drink half a cup a day. My ophthalmologist told me to drink it.
Well, it's sort of like, again, it's sort of a misunderstanding about what's happening. So beets have nitric oxide, right? So beets have nitric oxide, which is a very important metabolite or hormone, as it were, and it dilates blood vessels. So that's a really good thing for blood pressure. It's really good thing for so many parts of heart disease. I'm a big fan of beets, but you want to eat the beet in its whole form, ideally. And so when you eat the whole form of the beet, then you're getting all the other components, the fiber, et cetera. So when you juice, unfortunately, what you've done is you get some of the nitric oxide for sure, but you don't get any of the fiber and you get a whole lot of the sugar. So it's just something, the way, when you think about it, you can get beet powders, which are even a little bit better than the beet juicing, but not nearly as good as the beet as a whole. And so should you stop juicing or should you not? That's a very, you can decide on your own, depending, it all depends on all the other components of what you're eating, what your weight is like, how much your sugars are doing. But in general, beets are great. There's no restriction for diabetics it's just a matter of eating those whole foods where you're getting that chewing, you're eating that big fiber-rich item. That's a great food for most patients, most people.
Yeah, thank you. Yeah, there's something called beet boost that sometimes people take it as a supplement, like in water, beet powder, for example.
Yeah, so I'm a big fan of beet powder. I use beet powder because I don't love beets. But I eat them because they're so good for me. But when I can't I don't want to have beets or I haven't organized myself, I use a beet powder to help keep my potassium levels high and really be good with nitric oxide. It's sort of a nice surrogate, but I put it into my salad and then I eat it with my salad.
Cool. Pam would like to know if there's certain statins that are better than others if you have hypothyroidism.
Not really. Not really. Is there one better than another? Sometimes I'll play like Crest. I like Crestor a lot, rosuvastatin. I use Lipitor a lot too, which is a torvastatin. And so sometimes I can get lower doses on board with Crestor because it's a little bit stronger. So I might play with that. But they're not really like you'll be fine with pretty much any statin. It just sort of depends on what your LDL is. And that's usually how I make that decision on what statin to use.
Nice, thanks. And I hear about this a lot, the LP with the little a, and Lulu Girl is saying, what are your thoughts on a great lipid panel, but high LP little a?
Yeah, it's a great question. So LP little a is an atherogenic particle. So we call it LDL plus. It seems to be more atherogenic than just LDL. The study that you're looking for is ongoing and it should be out in 25, which is in people who have good LDLs or good cholesterols in general, and they just have elevated LP little a, what should we do about it? And should we try to treat somebody empirically for LP little a alone? And does that make you live longer? So that study will be out. It's called the Ocean trial, and that'll be out in 2025. In the meantime, many of us treat LDL as a surrogate for LP little a because we say, well, even if your LDL is good, since you have that higher risk factor, you should be more aggressively treated for your LDL because we're reducing the total number of cholesterol particles in your blood. Others of us will do, and what I often will do is I often do a calcium score in patients like that to see if they have plaque burden depending on the age of the patient. I don't do a lot of radiation in young people, but depending on the age, I might do a calcium score and then decide.
Nice, thank you. Oh, okay. Janet says, is a myocardial perfusion imaging the best way to see if your heart is functioning okay? Is the radiation you take in okay?
Yeah, so myocardial perfusion imaging study is just a stress test. And so it's a stress test with dye. Basically, it looks at the flow across your blood vessels. So like when I'm exercising, is the flow as good as when I'm not exercising? And that's what we're looking at and comparing. So they're good tests, and they're certainly tests that we use on a regular basis. Is it the best test for you? I don't know. I'd have to hear the scenario. Many of us have moved towards CT because the CTs have the same amount of the same amount of radiation that you're getting with a stress test, and actually arguably less now. So a lot of us are moving to CT. Now, I'm not sure what the scenario is. You may have already had a CT and somebody wants to do a functional assessment, and that would be appropriate. Is the radiation okay? Well, overall, in terms of radiation, we use a term called ALARA, which ALARA, which means to stay as low as reasonably appropriate. So we want you to get as little radiation as you can. But at this point, between the radiation scanners at the airport and the number of times we're flying and close to the sun in the airplane, we're getting so much radiation exposure that, a stress test a couple times in your life is not so bad.
Cool. Patty says, I was recently diagnosed with long COVID AFib. Is ablation my only choice? Do you do ablations, Dr. Aggarwal?
No, ablation's done by a rhythm specialist, which is an electrophysiologist. So that's another specialty of cardiac. So I'm a preventive cardiologist. So that's my specialty, and lipids, whereas there's a heart failure physician, there's an interventional cardiologist, and then there's electrophysiology. And all of these are just 4 different specialties of cardiology. So not necessarily. I mean, we have a lot of AFib post-COVID, and ablation is not necessarily the next step. It sort of depends on the scenario. Many patients are treated with medicine, or some people don't need anything at all. It all really depends on the scenario. Ablation is one route, but there are many routes to AFib.
Wow, that's cool. All right. I just saw a question on YouTube. It was from Marlary. Where did it go? I was skipping over to the different social media.
Okay, I'll tell another story.
Okay, great.
In the meantime, I had a patient who was diagnosed. She's in her 20s, and she came to me as a new patient. She's been frustrated because she's been told she has high cholesterol and she hates statins and they make her feel bad, and she's in her 20s. And so, I looked at her and listening to her story, and her LDL was as high as 320, which is extremely elevated. So I'm looking at her and I'm saying, well, guess, 20-year-olds usually don't have high cholesterol that high, and it's a genetic and frankly, anybody doesn't typically have LDLs that high. So I know she's got some sort of genetic problem. So, I do this genetic testing. I'm sure she's got something called familial hypercholesterolemia, and she doesn't. So I check it again because I don't believe it. And then I check it. And then the second time I figure out the cause, and she has another genetic disorder. And that's why she doesn't respond well to some of the medications she's been put on. So we have her now on the right medications, and she's doing extremely well, and we've improved her overall long-term outcome. So that's a genetically high cholesterol, but being with somebody who's an expert in cholesterol management or lipids can really help you understand if you're going to need medical therapy or not. Because if you have a genetic predisposition to high cholesterol, it's very unlikely that I will be able to keep you off of medications. That's the people who have a receptor problem, or who generate too much cholesterol, or have too many what we call chylomicrons. And these are genetic conditions that we're born with, that prevent us from being able to just use lifestyle alone. I don't think I must have a few genetic patients that I'm able to keep off medication, but often they will use a combined approach and need some medication. The point of that story is, I think, sometimes remembering that sometimes people want to, put you into a bucket, and none of us fit in a bucket. And we all don't, we have to be treated individually, and somebody needs to look at your individual picture to decide if you need how aggressive your care needs to be.
Thanks. Here, I found the question. What is the first thing that you tell patients to do for someone with a blockage?
So, difficult question to answer because I need to, again, know the scenario. Everybody has to be treated individually. If you have angina, that's a different scenario than if you're asymptomatic. Where the lesion is, what other risk factors you have, like diabetes or kidney disease, are all things that would dictate for me how aggressively or I would treat you. So I would need to know all of those things before I was able to answer that question. But whether we did an intervention or treated you with lifestyle alone or with medication or a combined approach would really be dictated by the answers to those questions. I know that people often when I do these Q&As, want to know, well, what do we do for me? And I want to be able to help and these broad answers are difficult for people who are just looking for that answer. But unfortunately, if you don't want to be treated, as I pointed out, like you go into a bucket where everybody is treated the same, you don't want to be treated that way. You want somebody who's looking specifically at your condition, because so many patients are getting too aggressive care, and then there's others who are not getting enough.
Yeah. Debbie would like to know if you saw a study that says that HRT is beneficial for women over 65.
I don't know of any study that shows that HRT is beneficial for over 65. And in general, I do a lot of women's health and women in heart disease, and so I will allow some HRT in patients post-menopause, but not typically as late as 65 years.
Elle says, what is a normal blood pressure range?
Yeah, it's a good question. Sometimes it's a moving target for some people. So in general, we want your number to be closer to 115 over 75. So that's where we want you to be closest to. Now, there's studies that show for every 20 points above that 115 that you slightly increase your risk. Now, I don't want you to panic if your number is like 132. A lot of people live in that 132, 130 range. And those people often aren't treating with medications necessarily. In general, the way to think of it is you'd like to keep that top number under 135 and the bottom number under 85. That's a general rule, but whether we treat you with medications when it's higher than that is really dictated by what other risk factors you have. But women often will have really low blood pressure, especially thinner women, and they could have blood pressures of 90, 95, 100, and that could be completely normal for them.
Thanks. Here's one. Renee says, I have a friend who's vegan, sofa's free, but still has to take blood pressure meds. He's an ultra athlete. Is it genetic?
Could be. Yeah. I mean, 95% of high blood pressure is genetic. And sometimes, though, I would caution that person, if they're an ultra athlete, making sure that if they have big muscles in their arm, that somebody's using the right size cuff. Sometimes people use a regular cuff and an athlete who really needs a large adult cuff. And then they get told that they have high blood pressure. But yeah, we do see essential hypertension or high blood pressure in people who do everything right. And so I always remind people, imagine how your blood pressure would be if you didn't do everything else right.
Yeah. Terry commented a great, the stress level point. How does stress affect your heart? How does it affect everything? I mean, it seems like it's the root of so many things.
I think our world has changed. We live in a concentrative of sympathetic tone, elevated sympathetic tone. So it goes back to that comment I made earlier about that needing to balance your sympathetic and parasympathetic nervous systems, where we don't want to be too rest and recovery, but we certainly are not. We've gone the other way. We're like 70% fight or flight. So that's a stress response. Remember, a stress response is, we need a sympathetic nervous system, which is, you're running from a tiger and you run and your heart rate goes up and your blood pressure goes up and you don't have the urge to urinate and you don't need to go defecate and you're not hungry. That's a sympathetic nervous system, and you don't really feel pain. And that's important, because you're running from a tiger, or if your kid gets sick and you need to just be up and be on point, you need that response. It's just that then after that, after all that's recovered, you should sleep or recover. But none of us do that anymore. We're on our phones, we're tinkering around. I mean, I was on the way to take care of something for my house, and on the call, somebody's calling me for suggestions on this patient. I'm answering a text message. I'm thinking, what is going on? We're going back to that sort of high levels of stress all the time. So I have to actively force myself to pull away from things, and I give myself quality, quiet time where my phone is not with me. And the weekends, people say, I texted you. And I'll say, okay, I would love to chat with you, but call me on my home phone then, because my cell phone is not available to me on my weekends.
That's amazing. I got to start doing that. Oh my God, that's terrific.
It's
Hey,
so hard, but
it
I don't know if
really is, especially if like you're using it like as an alarm and things, things like that. So yeah,
I bought my kids we all bought new alarms. They're little cubes, like $10 from whatever Target or Amazon or wherever I bought them. And my kids were like, how does this thing work? We're like, okay, well, you plug it in, you would put it into the thing, and it works. And they were so blown away by that. And everybody has to put their phone down in our office. Now, it's not always perfect. And for me, I worry about my parents, not, if they're calling, if they have an emergency, not having the phone nearby. So I still sleep with my phone near my bed, but I have a sleep function or a focus function on. So at 10 o'clock in the evening till 7 in the morning, I have it on focus, or I don't know what's called sleep or do not disturb or something. And so my phone, unless it's an emergency call from my specific people, I won't get a call. And that's really important. I mean, you need that time to recover, the time where your mind is not moving a mile a minute. Like, well, how many times in your day can you say that my mind was quiet? And so people always have this focus on, oh, I got to meditate. Well, meditation is incredible. I'm a huge believer in meditation, but what people don't realize is that if you meditate for 15 minutes and the rest of your day is chaos and constant movement, well, certainly having that 15 minutes is important. But what we need to all work towards is learning how to bring that calm into our day to day, every single day. How do we bring in that calm? I see so many patients these days, and they're coming in with heart rates that are very elevated, of palpitations. And often it's because they have so much sympathetic tone. They're so stressed. Their heart rates are 80s to 100s at baseline. And getting them to just sort of recenter and recalibrate is not easy, but it's definitely something that needs to be done.
Yeah. Are you familiar with a study that a lot of people are talking about how supposedly, and I say supposedly because Dr. Goldhammer doesn't agree with this because he says it's not about doing the intermittent fasting, but what the person's eating, that intermittent fasting is linked to a higher risk of cardiovascular death?
Yeah, it's a great question because it's made a lot of news and something that I love to talk about. So glad you brought it up. So the study wasn't optimal. It wasn't a good study. So what people don't realize is in that study, they looked at two cohorts and two groups, which is what the cohorts are groups. And the group that was in the intermittent fasting group were sicker. They were more smokers. They were older. And so you're not comparing like items. So they're saying that the intermittent fasting group did worse. Well, it's too much of a stretch to say that when you didn't use an equal group, having more smokers, older population, also lower socioeconomic class. All these things contributed to that, the reason for those outcomes for being worse. So most of us who read the data and read the study have come out and said that the study is not needs to be taken with caution, and that we do not feel that the study was done with an equal cohort. And so I'm not a believer that intermittent fasting worsens your heart disease risk. At the same time, I'm also tell people to be cautious with intermittent fasting because even though I believe in it, I think it's great because I think that there's some data on inflammation, also shrinking the stomach. There's also data that says if you eat the same amount of food in that time window when you're eating, you're not going to be better, right? I mean, if you eat for 6 hours, but you eat like a steak and French fry, I mean, like all those foods that you normally eat, and you stuff them into that 6 hour period, you certainly are not going to lose weight. Which is why most people are intermittent fasting anyway, which is to lose weight. And in fact, studies show that intermittent fasting and eating the same calories in the 6 hour period versus all day, there's no difference in weight loss. So intermittent fasting to sort of shrink the stomach and to eat regular portions during that 6 or 8 hour window, well, that's really great.
Yeah, that's great. Thank you. I mean, it's funny, people hear like one study and they don't explore it more or look into it. Like, what do you think about the like don't have a banana with blueberry craze now, that
Right,
everybody,
right, right, right. So I think that's the thing, and social media has made this so much worse. And we've seen this with political issues as well, because somebody will say, "Oh, I saw on social media that this happened in this country or this," and it's promoted actually major issues, right? And that's why Facebook and other people have been under scrutiny. I think that social media has done us a great service and a massive disservice, because this is where people are getting most of their information now. And I have a TikTok account. I don't really know how to use TikTok. I'm embarrassed to say, but partly I think I'm just a little bit older than that demographic, and so it's hard sometimes, and it's so loud, so I have trouble with it. But I do have an account. So I was looking on it, and I was, it's amazing to me what people are saying about how we should. And I'm not suggesting that the person who asked the question gets their data from TikTok. It's just, it's really hard to know what to do anymore, because you can really find somebody who will tell you that almost anything is correct. And I think the only thing I would say is just watch your sources, because it's overwhelming. I have a book, I'm part of a book club, and it's 8 lawyers and me. And 2 of them are judges. I mean, these are like super powerhouse women. And they turned to me the other last week and they said, "But what do I do? What should I eat? It's so confusing." And so I don't usually sort of have a nutrition-based conversation unless somebody directly asks me. I don't volunteer it out of the blue. And so when they asked me, I started having a little conversation with them, and I asked them, I said, "Would you like to know the data of why I think that way?" And so it was interesting, because they said no. Uh, And these are highly accomplished women, and they said they don't want to. They just said that they want to. They trust me, and so they want to just know what I think and just give them a list of things to do. And so I think that's what I thought about that a lot. And I think a lot of people are looking for somebody to trust and to know what to do. And I said, "Okay, let me give you a little list." So I gave her a little list of some things to do. And I think that that taught me something, is to remember that sometimes people aren't looking for the data of the why or the trial, like you point out, is that people are just looking for the answers of what to do, like 1, do this, 2, do this. But if that's the case, you got to be really careful about your sources, because I can think of 5 names that are super popular in social media right now. They have 300,000, 400,000 followers, and I don't trust them.
yeah, it's scary, isn't it?
It is scary.
Yeah. I mean, and that's what I don't understand. Like, I would, if my doctor, like the one that I see, would tell me that, like not to have a blueberry with a banana, I would do that. But why would you just listen to somebody that's not your doctor?
Right. I agree. And I mean, it's
It's
crazy
just
that
weird.
people are
It's just
saying,
weird to me that people, I don't know. Like, it's just, I mean, because I do go to a plant-based doctor, and I feel like if that was actually true, he would tell me stop doing that. Not that I like eat bananas and blueberries all the time, but I mean, like if I'm going to have a smoothie, guess what? Those are going in there.
I think that if we just stick with the basics, I hear things every single day in practice. Like, what do you think about this? I saw this on social media. I can't have this with this, or is there a timing thing, or what about, I mean, I hear it, I hear everything. And so I just caution people to find people you trust. And when I say find people you trust, unfortunately, if they're good looking and they're cute and they're walking around in, whatever, that they may be smart too. I'm not suggesting you can't be both, but just be sure that they have credentials behind them. Like, what is it that I mean, there's so many people out there now that are advocating nutrition, and they're walking around just showing off their body, and they're saying, "Well, look, I eat this way, so this is why you should listen to me." Well, gosh, well, hold on a second. Is that right for you individually? Does this person have any credibility, and are they just, and just be careful, because that line is so tricky, and I see it over and over again that people are doing things because and I'm not saying that again that that person isn't smart or this person isn't smart. I just want to make sure that we're looking at the right people and making sure that we know who are they. And there are a lot of doctors out there that are surgeons and they don't have any, and not to say surgeons aren't doctors, but they have a very different training complex. So did they do any training in obesity? Did they do any training in nutrition and lifestyle? I mean, so before you start saying that these are the doctors that we should follow, just be cautious, because there are many people out there that are very, very popular that have no credentials in this space.
Yeah, thank you for saying that. This looks more like a comment than a question, but its husband had left EF 10%, cause unknown, but had mono when this started. Cholesterol 130, no blockages, followed Esselstyn diet to the letter. EC echo yesterday, 55%. So do you get a question out of that, or
Well,
maybe?
I mean, I would like to just be cautious that that was probably not necessarily diet related. That, you know, I'm a huge believer in diet, but that function of that heart probably would have recovered either way, because that was a viral induced cardiomyopathy, or presumably like a virus induced. And often, just like we recover from the cold, our heart recovers from the cold too, and recovers, and the function of the heart will recover. So, you know, I love that you change your diet because it's great for your heart disease risk and overall, but I'm not sure it's what improved his heart function.
Thank you. I forgot the question that was pre-submitted. It's from Anonymous. Is a visible suprasternal notch pulsation considered normal?
Could be in a very thin person. Some people just have a lot of sympathetic tone. Their heart rates are up. They're very thin. They have prominent suprasternal notch, and you might see your pulse if you're, especially if you've just run or exercised.
Okay. They have their stats if you want. Total cholesterol 227, LDL 126, triglycerides 265, CRP 4.2, omega-3 index 3.2. Are those good numbers?
So separate from the suprasternal notch question, they're, you know, they're not awful numbers or they're not bad numbers. And it's just, could they be better? I mean, I'd like to see that HSCRP lower. I'd love to see that LDL lower. So could I see better numbers from that person? Absolutely. Are there things that, do they need to be on medicines? Not necessarily, but there's often lifestyle changes I would suggest to bring those numbers down. I really like to see that LDL under 100.
The person says they're highly anxious, no exercise, gained weight from and are overweight. Yeah.
So maybe there's some room with lifestyle to, and maybe,
Lifestyle improvements can be made, in other words, right?
yeah, it sounds like improvements can be made, and maybe that anxiety is what's holding that person back. And is there a way for that anxiety to be diffused, whether that's through therapy or through exercise? I was reading a great study yesterday that was talking about exercise and the benefits. Well, yeah, all know exercise is good. But it was actually showing that exercise is so much, maybe even better for people who are depressed. So that was kind of an interesting thought, that maybe depressed people actually do better with exercise than other people. And it was also noting that, you know, 1/2 of us as Americans do the recommended amount of exercise on a daily. You know, I thought that number was actually high. I didn't realize even 1/2 people do it, but 1/2 of the country is
I
not doing
I
enough.
heard the numbers were much lower. I heard like 6% of people
Yeah, yeah,
regularly
actually,
exercise. Do
I'll look
you?
that up to confirm because I
Yeah.
saw it. I was reading it. Actually, here's my journal right there. And so,
So maybe people are doing better. Do you exercise? I do. I don't like it, but I just do it. Like it just became a habit. Like 12 years ago. Like once it became a habit, I just do it. I don't think about it anymore.
I love to exercise, I would tell you, because I need the endorphin rush and also because it diffuses my anxiety.
Me too.
So
That's the main
I,
reason I do it. And I got
yeah,
to
I
do it.
love it.
I got to do it
I
first thing in the
exercise
morning.
almost every day.
Yeah.
Yeah, so it says about only about 1/2 of Americans over 18 meet national guidelines for aerobic activity. So half.
Wow. I remember when I was in school, they took physical education away.
Yeah, I mean, there's a lot. Somebody was making a comment to me. I do a lot of teaching, so I had some residents with me, and they were learning from me in my clinic. And they said, you know, I remember when we used to have the Presidential Fitness Award, and he said we don't even see that in our elementary schools anymore. And so my daughter, luckily, my kids are very active and play a lot of sports, but there's no need. They don't have any PE requirement after 7th grade. So, you know, these kids who are always on their phones as it is and gaming, then are not even having PE, is mind blowing.
What do you do for exercise?
Ah, I love to exercise. So I run 3 to 4 days a week, which is probably too much. Usually 3 to 5 miles, and then I also I do like a stepper, well, usually one day a week, and I've been lately rucking. I don't know if you've heard about rucking, but I
I don't know
use it.
what that is.
Yeah, it's kind of interesting. It's a lower impact form of cardiovascular fitness where you wear a weighted vest. It's a backpack, but it's like a weighted vest. And I carry 20 pounds and I walk about 3.5 miles.
That's pretty good.
Yeah, I like it. I love it. Oh, and I work with a trainer twice a week.
Yeah, I love this. I love when I have like a person to work with. It's so cool. I'd love to do
So
that.
fun. I know.
It is great. What do you think of ultra low LDL in the 20s? Is it good or too low? High dose statins and whole food plant-based if trying to reverse CAD. Does ultra low LDL worry you, or do you think the lower the better?
Yeah, it's a good question. That's actually a great question because there are many of my partners that aim for an LDL of 0. I'm not one of those. I tend to I know that when you're born, your LDL is 40 to 50. So I keep your LDLs low, but I may not keep it at 0. So an LDL of 20s depends on your severity of your disease. I might decrease meds to keep, but I usually, depending if you have advanced heart disease with multi-vessels involved, I might keep your LDL 30 to 50. If you have very mild disease, I might be comfortable with an LDL of 50 to 60. I always try to remind people that your LDL is 40 to 50 when you're born. And so that's if you can build a baby into a human adult, I mean an adult human with 40 to 50 of LDL, then we certainly don't need to be higher than that. And maybe we need to be a little lower than that for reversal or at least stabilization. So I have some patients that I keep in the 30s, and that's where I like to have them. But I don't have a whole lot of patients I keep lower than that because I kind of keep, I'm not sure I don't think we have enough data to know that an LDL of 5 or 10 or 17 is okay. There are some studies that show LDLs as low as 17 are okay, but not a whole lot of long-term data on that.
Thanks. Uh, Winky says, I had HA from a spontaneous coronary artery dissection. Are you aware what that is? I had an
What is
HA. I don't know what it is.
HA? I mean, there's hereditary angiomatosis. I think that's what they're talking about. So they can have problems with their blood vessels and they can rupture. I imagine that's what they're talking about, but I'm not sure that if they sort of set it as a non-abbreviation, I could probably explain
Okay.
that to them.
Okay. Yeah, please type it again. Thank you. Patty says, I hate the meds metropropol and fic. Hey, this is why I'm not at Fico. I don't know, but wish there was something else I can do. I believe that she's the one with the AFib, maybe, was it?
I don't know what the second one is, but no
See, I'll put my
metoprolol.
glasses on. Oh, flecodide,
Oh,
FLE.
flecainide, flecainide,
Yeah,
sure, sure,
sorry.
sure.
Can't see.
Yeah, that's okay. Metoprolol is a great drug, but people have a love-hate relationship with it, and some people just can't tolerate it. I have 20-year-olds on metoprolol and love it. They just love it. It all depends on, I find, what your heart rate is and how much sympathetic tone you have. If you're kind of a chill, calm person with a low heart rate, you're not going to typically like metoprolol. So I get it. Metoprolol and flecainide are often treatments for AFib. And so you have to be on a case by case basis to see if that was appropriate or that could be weaned off or there was another option.
Hmm. Does eating fresh grapefruit help to bring blood pressure down?
I think anything that's potassium rich is going to help you bring your blood pressure down. So eating as many fruits and veggies in general is going to be good for bringing your potassium down. I typically won't say eat this one vegetable because I think then that starts this movement of like, okay, Aggarwal said I got to eat all these tomatoes, and so then they eat all these tomatoes. Yes, tomatoes are very high in potassium. That's great, but I want people to eat a diverse palate as well because that's really good for your microbiome, which is good for decreasing inflammation.
Hmm. Lula says, I have a tear in my aortic valve. What do I do?
Tear in the aortic valve is not common. It's possible that they have a tear, but maybe they mean
Well,
It's
they're spelling it Tare.
Tare.
I'm just reading the word tear. Maybe that's
Okay, I
just
think that's probably a
misspelling.
typo. Yeah, that's probably a
Right.
typo. So you can get a valve tear. I mean, it's just not so common. And sometimes that's related to infection. It causes leaking of the heart valve called aortic regurgitation. I'm just not sure if they're referring to an aortic tear for sure, but because it's not so common. But if they do indeed have that, it depends on the severity of the leaking of the valve to dictate what needs to be done. Often those are just monitored. But tear is something, often is triggered by inflammation, I mean, an infection. So that's why it's confusing to me that that person has a tear.
Cool. Marlary says, I don't have heart disease or a blockage. I have a female friend, 64 years old, with a 69% blockage, no other symptoms, family history of heart disease. I want to know the first Primero lifestyle recommendation.
Okay, so basically saying he wants to decrease his risk. He has a friend that has heart disease and wants to know what he needs to do, and he wants to know the number one thing he needs to do to reduce his risk. Is that right? Did I get that right?
Sounds like the best thing you can do. Yeah. What's the first
The
thing?
best thing you can do is to eat really well. Best thing you can do is eat plants.
Oh, oh,
Um,
Lula says, can people see you? So are you just in Florida or are you virtual as well?
I see patients virtually in only 4 states: New York, California, Maryland, and Florida. I was like, what is the other state? Florida. Those are the states, but I can't see Medicare. I can't see Medicare patients on my telehealth clinic because I see Medicare patients in my in-person clinic, and Medicare doesn't allow that. So I can see telehealth patients in those 4 states and only those 4 states. I know that's a source of tension because I get a lot of emails every week telling me I need to expand where I can see patients. And I do need to do that, but I have not. I need another person. This is going to be my clone who's going to take care of all my paperwork. But I can see people in person with Medicare or without Medicare in Orlando, Florida, where I see patients.
Hmm, cool. So Jean says, I'm 5 years post-ablation. I'm obese, but I've stayed out of AFib. When I got the ablation, I was put on Eliquis and Ticocin. Is it ever possible to get off these drugs?
Yeah, it's interesting that they chose that. My guess is you had AFib post-ablation, and that's why they put you on Ticocin, because Ticocin usually goes away once we do the ablation, and so they don't typically need to be on it. Now, the Eliquis is separate. That's based on sort of your risk profile for stroke. So if you have a high risk profile, which means if you're diabetic or you've had a stroke, or you're an older woman over 75, or high blood pressure, there's a combination of different things which dictate if you should be on Eliquis. That's separate than the Ticocin. The Ticocin usually would go away when the ablation's done if we thought there was no recurrence of AFib. But the Eliquis might stay just for decreasing heart disease risk. So maybe you can come off of Ticocin. It's something to talk to your doc about. Because sometimes what we forget is doctors are super busy. They're running around seeing a lot of patients. And so they may forget to de-escalate therapy, which is a real problem, I think, is I'm a huge believer in de-escalation. But you have to have a lot of time and be able to look at the patient fully to make a decision if you want to reduce a dose. And sometimes people just forget. So you might remind your doctor, like, do I need to be on Ticocin? Is that something that can be weaned off? Is it worth a try? I've had an ablation.
Hmm, interesting. So Patty says, the longer I was told that the longer I have AFib without an ablation, the more damage to the heart. But what can I do to help AFib otherwise because I'm afraid of all these meds?
Yeah, I've been asked to do a talk on AFib because the AFib question comes up a lot. It's interesting. I didn't realize this was such a common question. So AFib, depending on the cause, it can be treatable. Like it's important to know why you have it. So if you have AFib from thyroid or obesity or sleep apnea, so I always tell people in my residence when I teach them, I said, always ask yourself why first. Like, why does this person have this problem? And then you should be able to understand what those risk factors are. And then you should ask yourself, well, then you should ask yourself what to do. And so like if they have this problem, then you're going to do this. If you have this problem, you're going to do this. So if you can figure out what is the reason for the AFib, then often treating that will treat the problem. But there are people who have what we call idiopathic AFib, which is we don't really know why they have AFib. And so those are people that unfortunately they get the raw end of the stick because there's nothing that we can noticeably treat to make them better. And so, that's always tricky. And so those are people that we have less things to do, but there are, things some people have thought about with AFib that may or may not be benefit. We used to think omega-3s were really good for AFib, but then some of their more recent data said maybe you get more AFib with omega-3s. I often tell people that the key is to figure out the why. So why you have the AFib, and that often will tell you what to do.
Okay. Here is a question from Monica. If someone is out of breath when doing tasks or walking, can it be a heart issue, and what medical tests would be best? How do you know it's not asthma?
Yeah, I mean, it's more, it could be either depending on your age and your risk factor profile. It could easily be asthma or just deconditioning, just being out of shape. But it could be heart disease, especially in women. Women often don't present with chest pain or the same uneasiness or pressure that men present with. And so, depending on your risk factor profile, testing like a stress test might be worthwhile. I mean, I've done 10 stress tests on myself, where I just put myself on a treadmill and exercise because I can. And so I have that benefit. But I sort of think that an exercise stress test is a very benign test. You don't get any dye, there's no radiation. You just put some stickers on your chest and exercise. So if there's some concern, you can ask your doctor for a stress test.
Somebody's asking if you know a plant-based electrophysiologist.
I don't think so. Not that I can think of offhand. I mean, remember, there are not many plant-based doctors as it is. And there's not that many plant-based cardiologists, even though, AJ, you seem to know a bunch of us, but there are not a lot of us, truthfully. And
Interesting. Mhm.
I don't know. I don't know if I can think of somebody offhand that's an electrophysiologist. Is Columbus is interventional? Yeah, no, I don't know one offhand.
Yeah. What do you think of apple cider vinegar?
I mean, it's a good vinegar in my cooking.
Mm.
So, a lot of people think apple cider vinegar is going to be a cure-all. It's going to bring your blood pressure down. I mean, I studied this. I wrote a paper on this, a chapter actually in a book. What book was it? Medical Clinics of North America. I wrote about apple cider vinegar. And as far as I can tell, unless there's new data in the last year, apple cider vinegar doesn't do a whole lot of difference. Now, whether it makes you change your behavior and eat cleaner and you've done a whole lot of other lifestyle changes and that contributes to why people get better with it, maybe, but in terms of the studies, there's no real data to say we should be on it.
Mm. Somebody's asking if you can get AFib from having your thyroid removed.
Well, the surgery, post-surgery, again, it's that sympathetic tone thing. So high levels of stress can absolutely trigger atrial fibrillation. Post-op atrial fibrillation is extremely common.
Can stress in general trigger AFib?
Yeah, it's a good question. I think anything where you have too much sympathetic tone can be a trigger. Like I had a patient who had a cold and was having a lot of cold symptoms and then started Nasonex or one of those nasal, I don't know if it's, I think it was Nasonex, and he developed AFib from it. So you can sometimes trigger. I remember a resident when we were in residency drank a little bit of too much alcohol, was having a good time, and that went into AFib. That's called a holiday heart, where we go drink too much and you sort of trigger this kind of catecholamine response and you trigger AFib. So conceptually, anything that's going to stress your heart, fevers for sure, anything that's going to cause overstimulated state could put you at risk.
Yeah. So someone says, you mentioned your friends asking what to eat or not to eat. So can you share your thoughts on oil?
Yeah, in general, my study is very exciting. Is hopefully going to be published very soon about olive oil, which is great. And I think the answer to, and I'm not going to tell you the answer because you got to read the trial when it's officially published. But the short answer is that I wouldn't eat oil for health. If you want to use a little oil in your food for this or that, or there's a little bit of data on that people who are thin could probably handle some olive oil. There's some data on olive oil and blood pressure, but overall, I think some of the LDL reduction data isn't there. I think that overall, you shouldn't necessarily put oil in your body for health, but if you want to cook with a little oil, that's your decision. I wouldn't use it as this is good for me, that's why I need to eat it.
When will this study be published?
So I just got the second comments. So if I get off this phone and do them, then I'll be in good shape, and then it'll maybe go out and be submitted today or Monday, and then hopefully we'll have a response back in the couple weeks and then publish.
Oh, maybe the next time you come on, we can talk about it and then
That'd be
everybody
fun.
can read it. Okay, because
Yeah.
because there are some cardiologists in general and even a plant-based one that thinks oil is fantastic. And what I don't understand, and no one has ever really been able to answer this for me. And I remember talking to, I forget his first name, Kushi, the people in the macrobiotic place when I was at a conference with him, because they're very pro oil. And I'm like, if there's something that you feel is so good in oil, whether it's olive oil or coconut oil or flax oil, why wouldn't it be in the whole food? You know?
Well, it is in the whole food. It
Oops,
is in the whole food. So like why wouldn't olives are way better than olive oil, right? And so avocado is better than avocado oil, right? So one is a concentrated fat and one isn't. And so, you know, I think that olive oil has been very confusing. And, I actually um I've just been asked to be the chair of the nutrition committee of the American College of Cardiology, which is very cool and exciting and a great honor, and I'm thankful. And half of the nutrition group believes that oil is a good thing. And I'm not saying that they're wrong because there's a lot of data out there that says that oil is good. So people are confused even in the nutrition world. But I think that some of the newer trials coming out, and hopefully my trial will be impactful.
good, but compared to what? You know
Right.
what I'm
Well, that's
saying? Like,
always the
so
case.
yeah,
Always.
so should I start eating oil because it's good? I mean, it drives me crazy.
Right. Well,
Anyway,
that's why I tell people don't eat oil for your health, but if you want to cook with a little oil, okay.
yeah. Dan says, I recently had a coronary calcium scan done and the result was 1. Is it possible or feasible to reduce this to 0? And if so, how?
Yeah, it's a good question. Reversal of calcification in heart disease has been a question that we don't fully understand. I think that there's some anecdotal data that says you can reverse plaque, and there's some carotid data that says you can reverse. I think most of us sort of at least stand by that you can stabilize plaque, and maybe you can't get rid of what you have. Although all of us, including myself, have anecdotal, so that means cases that one or two, people have changed their diet and then the calcium score is 0. So I have seen that, but it's not enough for me to sort of say is a general guideline. Again, this is the best thing about being a scientist, right? And this is why I asked you guys to be careful who you listen to. If you make your decision based on 5 people having had an impression or done better, then that's a bad scientist, right? Because you can't look at 5 patients and make a decision for everyone. That's why we do studies, and that's why studies are important. Now, it's not that 5 people aren't important and they're interesting, but how do you know that that's for everybody? So you just have to be real careful. So what we can say for sure is that you can stabilize plaque, which is what we want to do. We can harden plaque, and maybe if we're lucky, we can reverse it. So if you have a calcium score of 1 and you go to 0, you're lucky. You might be able to. I think there's no harm in just eating. You should always change your diet. At the end of the day, if you make a lifestyle change and a dietary change and your number goes down, then you get to brag about it.
Yeah. Daniel's saying, are there any treatments for lipoprotein A? And maybe you could just briefly explain what that is.
So that's what we talked about earlier about
Yeah.
lipoprotein little a, and what that is that atherogenic particle that, or make plaque causing particle that's sort of more dangerous that we think than LDL. And so there are people who are, it's a genetic marker that we're seeing if you had it, you're probably going to have about the same amount. There is fluctuation. So people are like, well, look, it came down. I don't know about that. We do see some reduction, but there's often a fluctuation. There's some data that plant-based diets will bring down your LP little a. Statins in general will increase your LP little a. But that doesn't mean you shouldn't be on a statin. So let's be clear, just because a statin might increase your LP little a doesn't mean that you shouldn't be on a statin. But we don't know, we haven't found a study. We're doing the study, which is the Ocean trial, which will be out in 25, which talks about specifically reducing LP little a and how, if reducing it makes you better. In general, I tell people your goal is to reduce the overall number of particles of cholesterol. And so if you reduce them with diet or medication, that makes your risk lower. And that's what we should focus on.
Mhm. Yeah, this has been just great. And people are, I was worried like that because when we started, there was only one question, so we could keep going, but I want to respect your time. But just to clarify, the states that, because people are saying, as long as they're in the state at the time of the appointment, they don't actually have to live in the state that you're doing the appointment in. Isn't that correct?
So a lot of people have asked that question, and it's an interesting one. And I will just say it does matter where you are.
Okay. But how do they know? No. So we'll end with this fun question, and you've probably had it before, but not everybody maybe has seen the previous episodes. What does Dr. Aggarwal eat in a day?
Dr. Aggarwal eats nothing in a day. What are you talking about? Dr.
Okay.
Aggarwal loves to eat and is not ashamed to say it. So, but I am a very copious and I really listen to my body. And so if I'm hungry, I'm going to eat. But I don't, I also am not afraid to not eat. And I think that's something that people have trouble with. Like, I think we need more food than we do. And we really don't need a whole lot of food to live, especially with most of us having a sedentary lifestyle. Even those of us who exercise, like myself, we do spend about 80% at least of our day as sedentary. Even though we may exercise for an hour, 2 hours, you're still not getting a whole lot of activity. And so most of us don't need a whole lot of food. So what do I eat? Breakfast, I will have either steel cut oats with blueberries and cinnamon. I often will eat everybody knows that I am obsessed with hummus. So, I mean, people at Trader Joe's call me the hummus lady. So the hummus lady's here. So I often buy a case of hummus or because my kids also love hummus and they won't eat my fresh hummus. So it's always sad. Okay, so but I often eat a multigrain bread with no oil or sugar and no preservatives, completely fresh, made at a bakery. And then I'll add hummus and sometimes kimchi. I often eat sprouts. I eat a load of sprouts. I love to make green chutneys with mint and cilantro. I eat salads very, very regularly. I eat a load and load of salads, but I dress them up. I put beans in them and chickpeas in them and hummus, of course, in it because I'm obsessed with hummus. I eat a load of chickpeas. Sometimes I'll open a can of chickpeas and eat the can of chickpeas because I just love popping them in my mouth, rinse them and put them in my mouth. I eat a lot of beans. I eat a lot of lentils. I eat a lot of brown rice. Yeah, I mean, I guess that's what I eat. I eat tofu. I eat a lot of tofu.
What kind of hummus do you buy?
Yeah, so I buy my oil, the hummus I buy is not a no oil hummus. Because my kids they dictate the hummus in our house. And they love the garlic hummus at Trader Joe's. And they are like literally my son will eat 2 tubs of hummus with lunch, just so we're clear what that means. He's 6'4", and he's completely plant-based. And so he eats and he plays tennis on the team and he just a lot of sports. So he needs a lot of energy. And so he literally eats 2 tubs of hummus for lunch.
Oh my God, that's hilarious.
That's why people call me the hummus lady. So when I make hummus at home, I love to make hummus. It's just that because of popular opinion, I end up buying more of the garlic hummus than I'd like.
Yeah. It's interesting that you mentioned that you have oatmeal with cinnamon and blueberries because last night I was receiving from Dr. Neil Barnard the Voice of Compassion Award, and
Oh, I love
oh yeah, it's such a it's so heavy too. It's like this is really heavy. So
burglars beware.
he was giving a presentation on his new book, Power Foods, and he talked about even for weight loss, like blueberries are just so powerful and cinnamon so powerful, and you're having both of them together.
Oh my gosh. You could eat blueberries all day. They're so good for you.
Yeah, walnuts. That's the last question I'll ask you because somebody just said, because we were talking about oil. What about walnuts? Should we eat them every day?
Again, I don't know if you should eat anything every day. I'm not sure that there is anything I eat every day. I'm not sure there is, like, diversity is key. So eating some walnuts, or a handful of walnuts a couple days a week, sure. It just depends on what your whole thing is. Like if you're eating a lot of nut butters plus walnuts, then you eat almonds, then you eat a bag of cashews, then you eat, tofu. I mean, you may be getting way too much fat than you need. And so some people wonder when they eat a whole lot of nuts why they don't lose weight. Well, nuts in general are okay, but it's all about sort of it's your whole day's plan that you need to think about rather than one individual thing. And that's why I tell people there's not one thing I want you to eat. I don't want you to eat only tomatoes or only kale. Do I love kale? Yeah. Do I eat a lot of kale? Yeah. But is that all I want you to eat? No, I want you to eat a diversity and a wide palette. I mean, that euphemism or eating the rainbow is absolutely true.
Yeah, that's great. Well, this was just a wonderful
That's fun.
talk. I didn't I, like at first I'm like, she doesn't have any, she doesn't have a
I
topic,
know.
but
She's like, what is she going to do? What is she going to
well,
talk about?
I get worried.
Bored.
I sometimes I get worried, but there's no shortage of things to talk about with
There
with
isn't,
to the
and if
heart.
people are looking for things, I've actually been putting out a newsletter every week. If you go to drmonicaggarwal.com, if you sign up for the newsletter, that's been a really neat process for me, AJ. I write it every week, and it's been a lot of conversation we talk about death and anxiety and movement and peace and goals as we age. And so it's been a sort of a neat process for people to be part of. And the community has grown so much in the newsletter world and in my little newsletter, and the conversations that I get back are so cool. So if people are looking for connection, I started it for connection because I think people are looking for connection, people to connect with and understand each other and just be your whole self and your honest self. And it's been a very well received newsletter. And for myself too, it's something that I have also been nourished by. So if people are interested in finding out about me, they can go to my website, drmonicaggarwal.com, and check out the newsletter.
Great. Well, thank you so much, Dr.
Great,
Aggarwal.
great to see you. Great to see you
Same
all.
here.
Take care.
And thanks all of you for watching another episode of Chef AJ Live. Please come back tomorrow at 9 a.m. Pacific time for the Doc and the Chef. That's Dr. Jim Loomis of PCRM and Karen Dugan. And they're going to tell you why plants outperform collagen supplements. Take care, everyone. Bye-bye. Linda Middlesworth, if you're watching.